Okay, everyone, welcome. We're going to get started. Thanks so much for joining us for this evening's Knowledge in Motion lecture. Can you guys hear me okay?
Not well.
Yeah? Is that better? I'll just hold it. Thanks for joining us for this evening's Knowledge in Motion lecture. A couple of very quick housekeeping reminders before we get started this evening. Please remember to turn off your cell phones if you could. For those who are with us in person this evening, the restrooms are just down this hallway. And if there's something you need, food, water, anything of this sort, please just raise your hand. We have a number of volunteers stationed throughout the room. We're happy to give you a hand with anything you might need this evening. A couple of housekeeping issues regarding the lecture. Once our speaker is finished, if you have a question, when we get into the Q&A section, please raise your hand and wait for a mic to come so that people on the webcast can also hear your question and hear the back and forth discussion for that part of the lecture. And also at the end of the lecture, please remember to fill out a survey and return it to a volunteer if you could, so that we can get your feedback regarding Knowledge in Motion and continue to make it even better into the future. So we'll begin in a moment as soon as we get the okay from the online team. We're all good, team? Good? Yeah, great. So again, thanks everyone for joining for the Spaulding New England Regional Spinal Cord Injury Model Systems Knowledge in Motion program. And welcome to our webcast attendees who are with us this evening from 15 states across the US. And we have people joining us from as far away as India. So welcome to everyone who's watching us online. My name is Dr. Sherry Blauette. I'm the co-director of Knowledge Translation and Dissemination for the Spaulding New England Regional Spinal Cord Injury Center. And I'm here this evening to be your host and moderator. I wanted to make one very important announcement before we begin our lecture, and that is that just this evening, we're launching our new website. We're very excited about this. It's combining the best elements of our two prior Spinal Cord Injury Center websites through the prior two model systems. We've now joined forces and have a new and improved website that we hope everyone will visit. For all who are here this evening, who registered online, and those in attendance who provided their email, we'll be sending a link right away so that you can click on it and start to check out the contents of the site. Very rich with information, and we really hope that you enjoy it and use it as a resource. Some of the things that are available are introductions to the Spaulding New England Regional Spinal Cord Injury Model System and all of our staff, leadership, information regarding spinal cord injury research, including studies that are currently recruiting, more information regarding our Knowledge in Motion program, and other important resources, particularly resources for those with new spinal cord injury regarding opportunities in the community and resources, clinical resources available to you. In addition to just great information regarding upcoming events in the community. So we really hope you'll check it out, and we plan to, at the next Knowledge in Motion lecture, probably also do a demo for you so that you can learn more about it. So please tell others, spread the word, and hope that you can look into that soon. I'm now going to quick introduce our speaker, whom we're very proud to have with us this evening. Dr. Randy Trumbower, PT, PhD, joined us here at Spaulding in July of 2017. And prior to joining us here in Boston, he was a joint faculty appointment and assistant professor in the Department of Rehab Medicine, as well as biomechanical engineering at Emory University and the Georgia Institute of Technology, where he also served as director of research for Emory's Department of Rehabilitation Medicine. Dr. Trumbower is trained as a physical therapist and an engineer with advanced degrees in both, so very unique skill set for sure. He completed postdoctoral training at Northwestern at the Rehab Institute of Chicago and received his MS and PhD degrees in biomedical engineering from the University of Connecticut, as well as master's in PT from Duke. Dr. Trumbower's research focuses on the study of novel technologies to improve functional recovery for individuals with spinal cord injury, which he'll be discussing this evening. And his research has been funded by the National Institute of Health, Department of Defense, and other private foundations. So fairly impressive. We're very, very fortunate to have him with us on faculty and joining us this evening to provide a lecture that we hope provides interesting information regarding cutting edge research on recovery after spinal cord injury. Also, one last mention that Dr. Andy Taylor and Dave Estrada are running our online chat. So for those of you whom are tuning in via the webcast, please don't be shy about sending your questions via the web, and we'll be sure to include them in our Q&A. So thank you, and without further ado, I'll welcome Dr. Trumbower to the stage. Thank you.
Appreciate it. Well, thank you very much for the introduction. It's a real pleasure to be here. Let's see. Yes, it's a real pleasure to be here, and I want to say thank you to all of you for coming to participate in this lecture. There's a lot of information that I hope to share with you over the next 45 minutes, and much of this information is going to be hopefully spur some dialogue towards the end of the lecture, and we can have some communication and some discussion about some of the information I share with you. As Dr. Blau had mentioned, my name is Randy Trumbower. I am a new faculty member here in the Department of Rehab Medicine. There's a little bit of crosstalk, so I'm a little apologize. Let's not switch. Hopefully this is a little bit better. Is that okay? Yes. Wonderful. No? Can't hear as well. How about now? I'd hate to put this in my mouth, but it is a possibility. So the title of my presentation is Intermittent Low Oxygen Therapy, a breathtaking approach to improve function after spinal cord injury. I would have to say that much of the information that I'll be sharing with you over the next 45 minutes really is based on some tremendous effort of interdisciplinary collaboration. And I take the quote from Sir Isaac Newton, "If I've seen further, it's by standing on the shoulders of giants." And so as you can see, there are quite a number of individuals that have been key members of the collaborative effort. That is the collaborative effort to help restore function in people that have had catastrophic injuries to their central nervous system, and in particular, those that have had catastrophic injuries to their spinal cord. Much of my collaborations have extended across the United States, Emory University, Georgia Institute of Technology, as well as the Rehab Institute of Chicago, University of Florida, the Shepherd Center down in Atlanta, Georgia, and right here at home, the Spaulding Hospital, where I've had a great opportunity to build collaborations, even in the short time that I've been here, that I think will certainly help advance many of the questions that we are challenged with, which relate to why isn't there a cure for spinal cord injury? And what can we do to change that? Last but not least, but most important, the participants of the research that I'll be sharing with you today, these individuals, without them, much of the work that I'll be sharing could not have been made possible, as well as the funding agencies, most of which have been through federal agencies such as the Department of Defense, National Institutes of Health, National Science Foundation, as well as private foundations, Wings for Life, which is an international foundation located out of Austria, Salzburg, Austria, and the Craig Nielsen Foundation. So the key objectives for this talk are threefold. One, I hope to share with you the vision and mission of the laboratory that I direct. It's called the Inspire Laboratory. And it's just that, it's to inspire. And many of us have different definitions, or at least think of different ideas when we think of the word inspire. But I hope to share with you what our laboratory is doing to try to inspire others to try and come up with novel advances for rehabilitation, specifically for those with spinal cord injury. I will talk to you about this provocative intervention called ILOT, which is the low oxygen therapy. Sure. Just hold it? Okay. I'm kind of constrained to this space, so I apologize. I usually like to walk around with the microphone, but I want to make sure that the people that are not in this room can see me as well. So Again, if you can't hear me, then just let me know. And then number 3, I'm hoping that by the end of this presentation, you'll understand or at least be able to identify at least 2 clinical trials, large clinical trials here at the Spaulding Rehab Hospital that are aimed at looking at the efficacy of this intervention, ILOT, to help restore function in people with spinal cord injury. I will disclose that everything that I'll be speaking to you about today is of no financial interest to me. Arrangement or affiliation with any organization or business entity that could be perceived as a conflict of interest or source of bias in the context of this presentation. I have no financial interest, but I do have a personal interest. My dad, my mother-in-law, it's a little bit serendipitous that 2 people in my family close to me had spinal cord injuries, catastrophic injuries. My dad in particular, someone I cared for many years, passed away this past spring, and I would like to dedicate this lecture to him. He was a fighter, certainly had a very difficult time with his injury, and it motivated me, it's inspired me. It filled me with the urge to move forward and to come up with better solutions. Right now, a lot of the solutions that we're dealing with are frustratingly limited in rehabilitation. And when I see how I've had to care with my father and some of the challenges that he had, as well as my mother-in-law, it has certainly inspired me to build a lab, a career dedicated to helping those that have had injuries and also those that haven't had their injury yet. And so as a team, we're here to hopefully inspire others to look towards the mission of improving rehabilitation directed at curing spinal cord injury. How do we do that? So in our lab, the mission of the Inspire Lab is through the development of cutting-edge technologies that translate basic science breakthroughs toward functional recovery in persons with spinal cord injury. We believe in this concept of translation. Right? Much of the science starts in many ways at the basic science level. Very controlled experiments gives us some insight on key changes that occur within the nervous system that we can take advantage of and translate to that of people. And it's the idea that we can make this translation ultimately from the bench to bedside. How do we make an application available for people? In many ways, it involves this concept of translation. And in particular, the research that I'll be speaking to you about today is really dedicated to how is it that we can take advantage of the complexity of the nervous system, and we can harness and direct the way the nervous system reorganizes. And I'll argue and hopefully convince you today that the nervous system has tremendous capacity to reorganize and redevelop new pathways that can be extremely beneficial for restoring function. The Inspire Lab, in order to address this mission, to achieve this mission of controlling the restoration of function after injury, involves 3 very straightforward areas of focus: rehabilitation, engineering, and physiology. Okay? And under each one of those categories within the Inspire Lab, we ask fundamental questions. For example, in rehabilitation, how is it that one individual that gets the same therapy as me does better? Or maybe that they don't do as well? How does this rehabilitation that's so short-lived going to affect me years, many years from now? Why isn't rehabilitation available for me after I've been considered a chronic injury, where there really isn't much of a hope? These are all really important questions that we as caregivers and patients ask over and over again. Well, it comes down to what's under the hood. The potential for recovery often has to do with how our physiology behaves. How do we heal? The person next to me with spinal cord injury heals differently than me. The time course of recovery is different. In our lab, we look at ways to address those fundamental questions. Why do we recover differently? And what are some therapies that we can use to target individuals during different time courses and during different trajectories of recovery and make it more individualized? And then finally, from the engineering perspective, How can we make a difference? What are the technologies that we can use to take advantage of our physiology to better target rehabilitation for people? Every injury is different. As we know, every person is different. There are no two injuries that are the same, and therefore there should be never a therapy that should be targeting more than one person. Targeted therapy. We can do that with engineering technologies as they overlap with our understanding of physiology and how we perform rehabilitation. So again, why isn't there a cure? Unfortunately and fortunately, the nervous system is extremely complex. And the spinal cord, as it develops through the years, has no full potential to regenerate at this time, and the science has not yet found a way to solve this complex problem. However, I argue with 3 points. One, there are more than 100 trillion connections within our central nervous system. 100 trillion. Every cell that makes up within the nervous system has more than 10,000 connections with other neurons. And number 3, because of that abundancy of connections and networks, there's the potential for reorganization. I often think when I moved here from Atlanta and I started driving to work, I realized that my GPS was telling me a new route every single time I came to work. And I was wondering, when am I going to have a standard route to work? Well, as it turns out, the routes change. The nervous system adapts. The nervous system is always reorganizing. And I challenge us as rehabilitationists, as patients, clients, and researchers to understand what those reorganizations mean to us and how we can harness that reorganization in meaningful ways. And that is the point of ILOT. Okay? It is a fundamental intervention that targets the very air that we breathe. And I'll speak a little bit more about the details of that, but I will follow up with these emerging trends. Yes? ILOT, which is Intermittent Low Oxygen Therapy. And I'll speak to you about it. Yeah. I'll speak to you about it in a little bit. No worries. The emerging trends in spinal cord injury rehabilitation, they exist. Right? There's plenty of them. They all focus on, in many ways, how the nervous system reorganizes, how it heals. It can be in the forms of exercise, stimulation, both mechanical, electrical, as well as combinatorial therapies. There is no silver bullet in rehabilitation. When you think of other types of therapeutics, think of cancer therapies, there isn't one particular drug that seems to fix the problem. It's a cocktail. And I believe very strongly that in rehabilitation, the success will come from how we combine our therapeutics to act as synergies and improve outcome. These combinatorial therapeutics that we see in the clinic are good. They're great approaches, very clever, novel approaches, and you see some outcomes. But I will argue that a lot of these outcomes are frustrating and limited, especially for those that have had chronic injuries, more than a year, 2 years, 3 years out. A lot of these different types of therapies do not seem to have the same type of potency as they did when you initially had your injury. Which leads me to this provocative idea. And it came really from a lot of fantastic basic science research showing that breathing, which is the fundamental basis of our existence, we do a lot of it during the day. We do a lot of it during the year and throughout our lifetime. Over 8 million breaths in a year. During this talk, we may have almost 1,000 breaths. Breathing is a fundamental component of how we do many things. All right? And so the question I have is, if we manipulate the very air that we breathe, we are going to act or impose a stressor on our nervous system. And that stressor is something that we hope to encourage in a way that allows the nervous system to compensate. Imagine you have a spinal cord that's been dormant for many, many years. Wouldn't it be nice to begin to think of the spinal cord and the nervous system as a more acute condition, where the nervous system actually begins to go after some of the areas that have been damaged, as it did when you had an initial injury, where you saw some of that recovery. Can we turn back time on the spinal cord? Can we think of the spinal cord as more of a subacute, acute injury, not as a chronic injury? And what I'd like to do at this point is show you a video, if I can. And from this video, we'll speak a little bit more about the intervention. This was a video that was captured while I was down in Atlanta at Emory University. And it was supported through Red Bull and Wings for Life Foundation. And they were generous enough to put this video together, which I think is a nice summary of the technology that involves intermittent bouts of low oxygen therapy. The one study that we're supported through the Wings for Life involves walking, but I will also point out to you that certainly involves more than just walking. And I'll show you some of the data that certainly links this intervention to other potential functional return. Yes, sir.
Is reducing the oxygen from 21% to 9%, depending on the individual, high risk endeavor for brain?
Sure. So the question has to do with whether or not intermittent bouts of low oxygen can be detrimental to brain function. And the answer is, from our initial studies and from the rodent studies that looked at cell death and injury following these short bouts of low oxygen, especially in the areas that are important for learning and memory. And there has been no evidence to show that there's been any change in performance before and after the intervention. In rodents, they've looked at cell activity before and after this short bout of oxygen deprivation. And again, there has been no evidence to these short bouts. It's important to appreciate, and I will show you as the presentation goes on, that the exposure to hypoxia is, and I mentioned in the video, is not about long-term deprivation of oxygen. There's nothing good about that. It is the transient, quick changes in low oxygen level that trigger what we believe is a long-lasting effect on how the nervous system reorganizes. And that's key. When we deliver intermittent bouts of low oxygen, we are not increasing the level of CO2, carbon dioxide, and we are not imposing long-term exposure to these levels of oxygen. We are looking at less than 2 minutes of low oxygen, followed by room air. And from the multiple trials that we run so far, there has been not one deleterious adverse event to this therapy. Okay. Yes, sir.
Sorry, would you prefer questions at the end or while you talk?
At the end would be wonderful. Thanks. Nevertheless, I'm showing you alphabet soup right now. And this alphabet soup really tells you, if you're interested in the biology, I can go into detail later. But I do want to whet your appetite with potential mechanisms or causes for what exactly may be occurring within the nervous system when somebody receives intermittent bouts of low oxygen. And what we found is that, and from the video, is that it appears to affect the entire nervous system in some capacity. It has been shown to enhance breathing capacity and function in rodents with cervical spinal cord injury. It has been shown to enhance forepaw reach and grasp in rats with cervical spinal cord injury. I will show you that a recent paper came out last week that shows improvements in hand function in people with spinal cord injury. I'll also show you that intermittent bouts of low oxygen, when coupled with other therapies, as I mentioned, combination is key. The use of intermittent bouts of low oxygen therapy, ILOT, by itself has a weak effect. When you couple this therapy with another more aggressive, very specific therapeutic effect, that therapy enhances its performance. The person's performance is enhanced by that therapy. So it is a combination. It's almost like the analogy of a primer. When you paint a wall, if you don't paint the wall with a primer first, the paint does not stick. In rehabilitation, if you give somebody a therapeutic, it may or may not stick. They may not be able to consolidate what they've learned in their nervous system, and their performance the next time you give them that skill may not be as strong as you would hope. One of the things in rehabilitation is to come up with strategies in order to enhance the performance, the ability to learn a motor skill, a task, more efficiently. How do we do that? We engage the circuits. We turn up the volume on some of these circuits, make them listen better, such that when the therapy that we are giving to them in rehabilitation is more potent. And that's the idea behind ILOT. Of course, the question is about safety. Safety, we've been looking at safety for the last 7 years. And when I was postdocing in the Rehab Institute of Chicago, we've been extremely careful with this study and how we can translate the fantastic basic science that's been done in the rodent, those with rats that have had lesions and spinal cord injuries induced by scientists in order to study how these rats perform after the injury. But rats are not humans. So the translation from a rodent that lives 2 years to a human that lives 80, 90, 100 years, it's tricky. It's very, very difficult. But this is what we, in many ways, work with in the science world. So the big question that we had up front was, is it safe to translate this possibility of using intermittent bouts of low oxygen to enhance some of the circuitry and enhance some of the connections within the circuitry, which we call plasticity. And as I point out before, and I point out again, there is nothing good about long-term exposure to low oxygen. Nothing. Chronic hypoxia has limited therapeutic potential. It can cause hypertension, cell death, learning deficits, sleep disorder, and injury to the building blocks of our existence, or DNA. There's nothing good about long-term exposure to low oxygen. So this therapy that we have been studying is not about long-term exposure. It's about short transient responses to low oxygen as a stressor, a mild irritant, like you scratch the skin. If I were to scratch the skin over and over again, long-term, the skin would break down and you would end up with something really bad. If you exercise over and over and over again and do not allow the body to recover from the exercise, it's not good. If you drink water in voluminous amounts, it's not good. Giving intermittent bouts of low oxygen in short doses, small bouts, is a potential viable alternative that has been shown to induce the cascade of cellular changes that we believe is what triggers improved potency of connections within the spinal cord. The first study that we did was looking at output. How much, if you give an individual with a spinal cord injury, an incomplete spinal cord injury with some ability to move their ankle, can they produce more to the muscles that surround the ankle joint? If so, how much? And again, is it safe? So we did a study. We grabbed individuals that were interested with chronic injuries. It was a very broad population of people with spinal cord injury, those that have had ASIA C and D level injuries. Some could walk, some couldn't. And we exposed them to mild bouts of low oxygen, intermittently for 35 minutes. Before and after the intermittent exposure to low oxygen, we measured their strength. How much can they drive with their foot? The person that was asking them to push on the pedal had no idea whether they got intermittent low oxygen or intermittent room air. So every individual received, and they never knew because it was considered blinded. These individuals would wear a mask and they would receive air, and that's all they knew. And the air could be low oxygen with more nitrogen. As you remember, air is consisting of nitrogen, large amounts of nitrogen, about 21% oxygen, and a little trace of CO2 and some other elements. What we do is we tease out the oxygen and counterbalance it with nitrogen. And the individuals do not know whether they're receiving one or the other. They have intuition, but for the most part, they don't know. When they breathe in the intermittent bouts of low oxygen, things change. The respiration changes, the heart rate changes, and the saturation of oxygen in the blood changes. And what I'm showing you here, because I'm a very data-driven individual, and I'm going to show you some data. If you're a consumer of knowledge, if you're a consumer of science, if you want to be a consumer, an advocate for how we as a group can change and restore function in spinal cord injury, you need to look at the data and work with people that do understand the data. Data first. What I'm showing you here are data representing a response to intermittent bouts of low oxygen. At the bottom, you'll notice that there are numbers from 1 to 15. That's the number of times in one sequence of intermittent low oxygen therapy the individual received either room air or low oxygen. The height of the bar represents how much oxygen is in the blood. 100% is very good. 70% or lower is not good. What you can see is that the oxygen, based on those bars, goes back and forth between 80% and near 96%. Each time they received a low bout of oxygen, the oxygen saturation drops, and as soon as they receive room air, a minute later, it returns exactly back to where it was before they received the low oxygen. And you can see from these bars, as you go from 1 to 15, every single time they received a bout of low oxygen and then a return to room air, their oxygen saturation returned to normal. There was no long-standing changes in blood pressure, persistent low oxygen, changes in respiratory rate that we were able to detect after the trial. And this is the cool stuff. When we ran this trial, we looked at strength at baseline, which means what happens to your strength? What is your baseline strength? How strong are you before you enroll in the study? What I'm showing you here is every participant's response to the intervention. I'm showing you baseline. I'm showing you what happens 30 minutes after these individuals receive the low oxygen therapy. And then again, 60 minutes after they received low oxygen therapy. And what you'll notice from all these individuals is that you see a bump in amplitude of the amount of effort they were able to produce on a force plate, a plate that measures force, kind of like a scale. Just looking at the ankle, how much output can you produce from the ankle? The group responses of those that received, in this plot, it's called AIH, acute intermittent hypoxia. We refer to it also as intermittent low oxygen therapy. The individuals that received the ILOT therapy improved their torque production by nearly 80% on the average. When they received room air, there was no effect. We repeated the study. As scientists, we were excited, but we also wanted to know whether or not this type of phenomenon can be repeated. Can we grab a whole other set of individuals and get the same type of result? Or was this a fluke? And if it's a single day, how long does it last? 60 minutes after the intervention is fine, but does it last longer? How many hours longer? Can it persist for days, weeks, months, years? If not, then maybe the dosing of our protocol needs to be changed or optimized. We repeated the study and found similar results in these individuals. Strength increased across these individuals out to 90 minutes. And then what you'll find is that the level of strength depreciated after 3 hours. So the effect did not last for the whole day, at least in some individuals. So one intervention of intermittent low oxygen therapy does not seem to have a persistent long-term effect past a single day. But still, this was a proof of principle. We have an intervention that seems to have changed the ability to drive effort at the foot below the level of injury. Injuries at the neck or in the thoracic spine, the middle of the back, even though there's injuries there, we were able to strengthen what we believe, strengthen those connections and allow the individual to produce greater torque, greater effort at their foot. Why do we care about the foot? Well, if you think about the type of effort they were producing, it was what we call plantar flexion torque. It's what is your ability to lift up your heel, to do a heel raise? That's the type of effort we were asking these individuals to produce. 50%, half of the effort during walking involves that set of muscles. If we can enhance the effort of those muscles, we are ultimately enhancing more than half of the effort needed for walking over ground. And sure enough, we took this to another multi-site trial that involved Emory University, the Shepherd Center, a prestigious spinal cord injury rehab facility down in Atlanta, Georgia, as well as the Rehab Institute out of Chicago. And we asked the question, well, we saw changes in ankle force. They seem to have gotten stronger. The next question is, did that improve how individuals walk? Can you walk faster? If you produce more force with your foot, can you use that to produce more effort during overground walking? And the answer is yes. What was most intriguing is that the effort that was produced persisted out to 1 week. The difference between the protocol that we ran in this particular study was that these individuals received the therapy not just for 1 day, but for 5 days, 5 consecutive days. And the reason we did that was, again, going back to the studies that have been done before us in rats. The studies that they looked at were dosing studies showing greater effect when you expose these individual rats to longer, more frequent bouts of intermittent hypoxia. Not within a single session, but over multiple days. Repeat exposures. They had gone out to 2 weeks. In this particular study, we wanted to look at 1 week and to determine whether or not it was safe. As I mentioned, the protocols were really driven by the rodent studies, the rat studies. And what I can show you here is that, let me go back to that slide previously, is what really made us ask the question of walking over ground after spinal cord injury with and without this intermittent bout of low oxygen therapy was based on studies that were done at the University of Wisconsin and in Canada. And they took rats with small lesions in their neck, affected their ability to locomote, to walk, and they looked at behavioral changes. They said, okay, you take a rat that's had an injury, how well can they walk over ground, and how well, in particular, how well can they walk over a horizontal ladder? And this is a behavioral test for rats. How frequent can they manipulate their forepaws and their hind limbs such that their paws do not fall through the rungs of the horizontal ladder? And it's this behavior that gives indication of performance for rats and locomotion. And what they found is that these rats, when they were given 7 consecutive days of intermittent low oxygen therapy, that the performance of these rats that received intermittent low oxygen therapy improved to near the ability that they had before the injury. As you can see in the magenta, the performance enhanced after 4 days of therapy, and it persisted out well beyond 30 days. This was mind-boggling. They repeated this study twice in 2 different cohorts of rats and found similar results. What was most important about this finding was that these rats had training. It was not just low oxygen therapy that these rats were getting, but each day they were actually being trained on the ladder walking task. So rats were negotiating this horizontal ladder each day following the low oxygen therapy. And over the 7 days, the rats received low oxygen therapy with ladder walking, and the performance is what enhanced with the combination as opposed to just intermittent low oxygen therapy alone. So we decided to translate that to humans. Again, we looked at intermittent low oxygen therapy with intense overground walking exercise. And what we found in these individuals, again, it was a double-blind study, meaning that the person that was receiving the low oxygen therapy did not know whether they were receiving low oxygen or room air. And the clinician that was evaluating these individuals did not know what type of therapy they had. And what happened was very interesting. We had these individuals walking for 30 intense minutes of overground walking with their assisted device or overground harness system. And that 30 minutes of intense walking was coupled with oxygen therapy. All right. It's important to appreciate what the therapy was. The therapy was not designed to increase speed. The therapy was designed to increase endurance. And what we found when we looked at speed performance in these individuals that received the combination therapy, it was marginal. There wasn't much of an effect. The greatest effect came when we looked at their endurance. The endurance is what enhanced, which happened to be the same therapy that they were given in addition to the low oxygen therapy. So again, the results from this study seem to complement the results that were shown in the rodents. Again, translation. It's all about the translation. I had mentioned to you that one of the things that we believe strongly in this type of therapy is that it is more or less a primer. We showed in the rats that it enhances breathing capacity and forepaw manipulation and also walking and locomotion. If that's the case, then it's not unreasonable to suggest that we should see an enhancement in performance of hand function. As it turns out, we ran the same type of protocol, but this time instead of looking at leg function, we looked at hand function. And what we found across a whole battery of clinical assessments that looked at dexterity, hand opening, and speed is that those individuals that were given the intermittent low oxygen therapy along with hand practice of opening the hand and performing these skills was far greater than those that did not. I'm showing you here some representative data, results of the performance of these individuals that received low oxygen therapy with a hand dexterity test. It's called the box and blocks. They're essentially grabbing blocks with one hand and they're reaching and they're dropping them into an empty bin. We assess how fast they're able to do this task and how many blocks they can transfer in that period of time. If it's usually 1 minute. And that performance is graded as a performance of dexterity and speed. The individuals that received the ILOT therapy enhanced their ability to manipulate with the hand that they were not able to do before. Another assessment that we made in the upper extremities was looking at hand opening. So oftentimes in rehabilitation, we focus on closing the hand to grab a soda or a can or hold a cup of coffee. I argue that that's not necessarily the biggest problem. I argue that the biggest problem is hand opening. Volitionally hand opening and having the capacity to open not just all the fingers at once, but to individualize and to change the level of coactivity that's actually causing much of the issues with not being able to close or open. A lot of times the muscles on either side of the arm compete with each other, and they compete in a way that's actually extremely problematic. It's not necessarily about the weakness, it's about the control. Do we have the flexibility within our nervous system to control when muscles turn on and when they turn off? That's a big problem in spinal cord injury. And in this particular study, what we found was, yes, there were some marginal changes in how well they were able to open their hand. But what was really intriguing to us was that following the low oxygen therapy with hand opening practice was that the muscles they used to open their hand were far more functionally relevant after the therapy than before. Less coactivity, less spasticity. So the results that we've had so far are exciting. We have a number of clinical trials that we're running. The one I just spoke to you about with hand function is a clinical trial that we're looking to have individuals enroll in. The walking study, again, is a clinical trial specifically looking at how this intervention could affect those not only with chronic injuries, but those also with more subacute injuries, 3 to 6 months after their injury. How well can we produce greater output, not just for walking, but also with being able to move the lower extremities voluntarily. I've shown a number of different, albeit watered down to some level, different results that are compelling. But I'm not here to tell you that this is a solution. This is not the silver bullet. Despite all the promises that we have seen, again, there is plenty of work to be done to better understand what exactly is driving these behaviors. What type of, is this therapy right for everyone? Probably not. How do we better direct the therapy for individuals, depending on the type of injury they have, when they've had the injury, and so forth. There's plenty of unknowns. I'll give you two trials. We may be running short on time, but first one, again, there's lots of competition in the nervous system. Right? Remember all the connections that are there. Tens of thousands of connections within the nervous system. They all compete. Right? It's like traffic going to and from work. If you can't take this route, you take another route. Well, there's construction. Got to find another route. Competition throughout the nervous system. One of the things that we try to do in our lab is understand that competition and take advantage of it. Right? When there are competing pathways trying to do the same thing, they oftentimes compete and cause obstruction, actually reduce the efficacy of both. One involves intermittent low oxygen therapy. We have a good idea of the pathways that are involved that promote the effect that we see, the facilitatory effect, the promotion of greater voluntary output to the muscles. Right? That's great, but there's other pathways that do the same thing. And if they're both engaged at the same time, they dampen the effect of each. As it turns out, and as you could predict, we want to try to reduce the competing pathways, reduce the competition, so that when we're giving a therapy to somebody that has shown great promise with that therapy, we want to make it even better. So how do we make it better? We begin to look again under the hood. What, the why, the how, the neurophysiology. What does the physiology tell us? What is it about Mr. Jones that allows him to respond so quickly? Can we use some other types of therapies to help reduce the competition? As it turns out, you can. One of the clinical trials that we're running involves a way to reduce the competition. And as it turns out, caffeine is one way to reduce the competition. It acts on receptors that have a completely separate pathway that also helps facilitate output. If the caffeine blocks that particular pathway that can facilitate output, then we can potentially enhance the effects of low oxygen therapy. So that's one of the trials, is to use caffeine as a way to further enhance the effects of low oxygen therapy. From the preliminary data that we have so far, when we do combine those two, individuals perform far greater than if you do either one alone. And this is a hot topic, the genetic factors. I mentioned again, lots of promising discoveries of intermittent low oxygen therapy, plenty of benefits that we potentially see going forward. But there are plenty of genetic factors that can really help us guide where to direct these types of therapies. Remember the human genome. This is Genetics 101. We've got 23 pairs of chromosomes. Well, it turns out that the way that these pairs are copied over and over again within the genome, we make lots of copies. When we make copies, it turns into some errors, right? Copying errors. We all have errors in our genetics. We all have errors in our chromosomes. Some of them we can see. Maybe we have some curly hair, right? Or maybe we have blue eyes. That's because of an error. We call those little errors SNPs, single nucleotide polymorphisms. We all have some type of polymorphism. Some of them we can see, some of them we can't. And as it turns out, we're learning more and more about these SNPs and these little variations and how we sequence within our DNA that define us from others, and how we respond to drugs, whether we're allergic to drugs or not, or maybe how well we respond to the drugs. In the intermittent low oxygen therapy protocol, the magic piece of this entire mechanism is a protein. It's the brain-derived neurotrophic factor protein. That's the protein that has been triggered and connected with a lot of different ways for which our nervous system reorganizes, adapts. It turns out that many of us, actually 35% of us, so if there's 100 people here in the room, 35 of us will manufacture that protein differently than the others because of a SNP. And it doesn't mean that the protein that you manufacture is wrong. It just means that it's different. It's a variation. Okay? What happens is that you manufacture these proteins differently, and so your performance that involves the use of that protein is going to be different. We're studying in that. We want to know if a therapy is targeting that particular protein and individuals manufacture that protein differently, can that be insight into how they will respond to the therapy? If yes, we have markers. In rehabilitation, we don't have sufficient markers to make those types of strong directions for rehabilitation. We have to remove the one-size-fits-all and start looking at more targeted therapeutics. One way to do that is looking at genetic markers. So I'll finish the talk with 4 arguments moving forward. The vision. We need to look at the effects of ILOT long-term. Is it a long-term potential? Or is it something that will require the combination, just like with exercise? And if you don't exercise, you lose the capacity and the performance that you gained when you did exercise. The same may be the case for low oxygen therapy. Or it may actually promote long-term reorganization that lasts beyond the intervention. We need to understand that. We don't have an answer. Number 2, person-specific responses. One way to target person-specific responses is to understand the characteristics of the individuals that enroll in our study. One of the challenges with spinal cord injury is that so many people have similar injury levels, but it doesn't mean that they have the same functional outcome and performance. So the capacity for one individual to respond to a therapy is much different than another, and we need to understand the physiology for why that is. Number 3, combinatorial therapies. Combinatorial therapies is going to be the gold standard for rehabilitation. How do we couple mass practice of a task or a skill that you're trying to learn with drugs? How do we sculpt the nervous system? Is there a way to enhance the nervous system with therapies that prime, such as ILOT, with other therapies that are much more in tune at sculpting how the nervous system behaves? When I think of sculpting the nervous system, think of it in terms of reorganizing in a way that's directly related to the performance that you're trying to improve upon. Maybe it's sitting up. Maybe it's eating independently with your less dominant hand. Maybe it's writing your name. Any one of those is a skill that involves many different coordination strategies. And the question is, how do we combine these different therapies in order to enhance that outcome? And then number 4, probably the most important, There are so many conditions that undermine the effects of a lot of things that we do in rehabilitation. You come into the clinic, you come into the research, you perform, you make improvements, you go home, and we get a little bit of what we call washout. The great benefits you've received in therapy, maybe you use no assisted device anymore, or maybe you use one loft strand instead of two. You go home, and that chair is sitting in the corner, and you find yourself using something that's far more efficient for you to use than what you may have gained from rehabilitation. The challenge with that is any therapies that we have or we study, when we look at long-term effects, potentially get washed out by competing sources of therapy or sources of improving mobility and functional independence. In addition to that, we have many other issues. Probably the biggest issue in this room is inflammation. Chronic inflammation completely wipes out beneficial plasticity. It makes it really hard for the nervous system to reorganize in a beneficial way when you have lots of inflammation. And we're studying that. Does inflammation affect the eye lot? Probably it does. What if we were able to reduce the inflammation and provide this low oxygen therapy? Can we further enhance the beneficial effects? We don't know. These are questions. And certainly other medications that may be actually down suppressing the nervous system's output. Many of the therapies and drugs that we use, I call them dirty drugs because they do a lot of different things, kind of like caffeine. They do a lot of different things on a lot of different systems, and we don't quite understand how to target them to get the greatest effect on a specific type of response that we want. That really makes a lot of the research and questions that we have difficult to answer. And so with that, plenty of questions that I've posed. I know you probably have tremendous numbers of questions as well. I'm sorry I ran over, but I'm more than happy to answer as many as I can, or at least try to answer the questions as best I can. But I appreciate you listening. Thank you.
So thanks very much. Thanks very much, Dr. Trumbower. Really insightful talk, really interesting. So now we'll open it up to Q&A. We have circulating mics around the room, and also might get some questions from the webcast as well, so we'll insert those as those come up. We have till 8 o'clock, so happy to make this a discussion, and if people could please remember to be working on their surveys as well while we go into Q&A. So thank you. I know you've had a burning one here, sir, for quite some time.
I'm a T2 incomplete. And with every advance of movement I've received in my body has been followed by a corresponding increase in neuropathic pain. And I'm wondering, to the point which I have almost no interest in increasing my movement because I don't want any more pain. Is there any benefit with neuropathic pain?
So the question refers to the effects of intermittent low oxygen therapy on pain. And that is a fantastic question. And we are exploring that question as we speak. I did. No, that's okay. Pain is a very complex mechanism, and using intermittent low oxygen therapy, targeting those particular pathways that are involved in pain. One of the challenges with low oxygen therapy is that it targets that particular protein I mentioned, BDNF. Well, BDNF can actually increase pain. So one of the things that we are looking at very carefully is whether or not this low oxygen therapy may increase pain for those in some individuals. We haven't seen it, but we're measuring it. And so your point is well taken. And it's an important measure, and pain is a huge effect on quality of life. And these are things that we need to explore further, but we don't have an answer at this point. Yeah.
Practically all of the research that is done trying to repair spinal cord injury is done to repair traumatic injury where there is a break in one particular spot. Now, there is a smaller number of patients who live with ischemic damage who have multiple locations of damage. You said that ILOT affects the whole nervous system. Is anybody thinking about what this would do to ischemic damage and whether the results would be the same or different than what you would get if you were treating patients with damage in just one spot?
Sure. So I'm going to pull out probably two little questions from what you asked. One was, is there any benefit of ILOT to non-traumatic injury? And is there any benefit of ILOT to injuries that occur at different levels of the spinal cord, multiple levels of the spinal cord? And the answer is, why not? When we enrolled individuals into our initial trials, we did not enroll individuals based on traumatic injury alone. We had individuals with complicated disease within the spinal cord, non-progressive, within the spinal cord, and these individuals had an effect. So from what we can gather from knowing the mechanisms, as well as the types of injuries that we've seen, so long as there are networks within the spinal cord that transcend the injury site, whether they're active or maybe just sitting subthreshold at a level that's not producing any viable output, this intervention is fair game. That's our hypothesis. Okay? We are. So the individuals that are enrolled in our study are not just traumatic, they're non-traumatic. And when you have a non-traumatic injury, it's very seldom to be just in one spot. So what we'll find is that there's migration along multiple levels of the cord. With that information, I would say that it does affect those that have multiple levels of injury as well as non-traumatic injury. Yeah.
Question from the web, Dr. Trump.
Oh, sure.
From Trumbower, one of the webcast participants is asking, how long does it take before the effect of ILOT starts to show?
Okay, so the question is, how long does it take to have an effect of ILOT? So what we've measured is immediately following the 35-minute exposure in one sequence, and we have an effect. So the effect was, quote unquote, immediate. We didn't measure the effect during the treatment, so we can't say at what time during the exposure at sequence 1 through 15 did the effect start to evolve. All right, so what we found was that immediately following the sequence of intermittent low oxygen therapy, we saw an effect. And that persisted out to an hour. And if we took it to that second trial, we saw it out to 2 and even 3 hours in some individuals.
So if I understood you correctly, sir, this woman pointed out cerebral palsy would be a potential surrogate for.
So cerebral palsy, there's potential. We've never looked at this effect on cerebral palsy. And to be honest,
trauma.
Yeah, so that's a congenital disorder, and it's very complicated. That cerebral palsy is somewhat of I call it like a garden variety term for a lot of different changes that occur.
So my other question is about, have you done any work, because I realize it's very discrete research right now, but what about like using pneumatic exoskeletons and things like that in combination with?
Yeah, so pneumatic exoskeletons, different types of question is, are there other forms of therapies that you can combine with ILOT in order to potentially enhance the effect of the performance that the individual is trying to train on? And the answer is, that's what we want to do. We want to know, and our hypothesis, our working idea of how this intervention may play out in rehabilitation is that the power is when it's combined with other therapies. And if we have a therapy that's working, we want it to work better. That's the point. So with exoskeletal devices, we have a team down in New York at Mount Sinai that we're collecting and we're partnering up with to look at the effects of intermittent low oxygen therapy in conjunction with exoskeletal wearable technologies that assist with locomotion to see whether the combination of the two enhances the ability to locomote more than either one alone.
Could you explain a little bit more about what's known regarding the potential deleterious effect of inflammation? And I think maybe for the audience too, what are some of the most common types of systemic inflammation might be a point of interest and how that interacts?
Yeah, so, you know, right now, chronic inflammation, depending on the physicians and the individual that would enroll in our study, how much that plays out and how they're enrolled in the study is a big deal. So individuals that have had, you know, ulcers or any major forms of skin breakdown are generally not included in our study at this time. So we rule out anyone that has had or is currently undergoing treatment for any type of skin breakdown. Heterotrophic ossification, these are other issues that we rule out from participation at this time to be safe. Any one of these types of mechanisms that can induce inflammation, we certainly don't want to make things worse. And so for the trials that we're running right now and in the past, we have not included those individuals into the trials. We are at this point taking saliva from participants, and we're using the saliva as a way to gauge, believe it or not. There's markers within the saliva that can give us some insight into inflammation. It can give us some insight into your genetics. And those that are enrolled in the study, we take that information and we can provide some useful markers of whether or not this intervention is actually changing levels of inflammation. Or does the individual, as I mentioned before, have a SNP that may actually impose a constraint on how effective this therapy is for them? And so these are things that we're marking through saliva to better get a sense of who's the responders versus non-responders.
So you're at the genetic level with the DNA. You were mentioning about different responses from different individuals.
Mm-hmm.
And are you able to differentiate, anticipate? Are you trying to, it's like you're trying to get this stuff into a corner where it has limited options of showing variability. You mentioned about cancer cells mutating. They sort of do that on their own, but they're responding to something after them. And is it similar that you're trying to get, whether it's the low oxygen, intermittent low oxygen, but whatever the environment is, are you trying to look at the genetic response of the various DNA components?
So I'm
just because you're saying you're getting different responses, and that's what we've heard. You know, it's been very frustrating to say, well, somebody's got a C6 or they've got a C4,
mm-hmm.
and they're getting different results, and it may be a result of the genetics.
Right. So we're using genetics as a way to identify potential markers of response versus non-response, or response or greater response.
Yeah.
We want to know, based on your genetic makeup, the information, in particular, how you manufacture certain types of proteins that are important for recovery related to the therapy, influence how well you perform with the test that targets that particular protein. Okay, so the genetic information is used as a way to potentially in the future, the idea would be to make predictions that if somebody were to come into the clinic and we have a marker that says you have a polymorphism, a variation of how you produce this protein, you need twice as much therapy. Not 3 visits like your roommate next door. You need 6 visits because the efficacy for this therapy, and given your genetic makeup, will require you more time and more dosing than the person next to you.
All right, so you're developing the information, the data now to go beyond hypothesizing.
Yes,
Say, yeah,
we need, so these data are going to be used to provide and extrapolate models that will allow us to make some predictions of responsiveness for individuals that are in the clinic that have not had an injury yet, right?
Rita wants to know if, since you didn't mention anything for vent patients, if there's anything for vents.
So the question has to do with vent-dependent patients and the use of intermittent low oxygen therapy on those that are requiring ventilation, right? Our lab has not been focusing on vent weaning and determining whether intermittent low oxygen therapy could be a useful tool to strengthen diaphragmatic breathing and some of the other muscles that are important for breathing, and to maybe accelerate the weaning of dependency on a ventilator. My colleagues who are part of this team down at the University of Florida have been looking at vent weaning with intermittent low oxygen. And so they're running trials right now to assess whether or not the behaviors that they saw in the rodents with improved breathing capacity in rats with C2 cervical spinal cord injuries, where they return some of their volume, tidal volume, and ability to breathe independently is enhanced. In rats, they need to know whether or not the same type of effect can occur in humans. And so that is ongoing right now. Very good question, and it makes complete sense that we would be looking at, a stressor on breathing because that weaning process involves quite a bit of stress.
As one of those people with that ischemic damage that gets very little research done, I'm wondering not only necessarily how you do it, but how do we do it? Is there an opportunity or an avenue for people to start working with this independently so that they can find out if there's benefit, even if it isn't practical for them to try to get to some place where there might be a research study going on?
So how to get involved is the question.
How to get involved, but also it's like, okay, I'm glad you're doing it. How do I do it?
Right. So everything I've shown you is research. And I've shown you evidence that from our small sample sizes of 30, 40 people, 50 people total that participated at some point in these trials has given us some results. Not enough. It's not enough for me to say that you can take this home, put it in your living room, and start doing the therapy yourself. We haven't been able to get to that level. We are at a phase 2 trial, phase 1, phase 2, which is a very, very elementary. A lot of the things I'm talking to you about are cutting edge proof of principle. And where we want to go is to a large phase 3 clinical trial. To get there, we need more research participation. We need people to come in and actually participate in the studies. There are studies going on here. There are studies going on in Atlanta. There are studies going on in Florida. There are studies going on in Chicago, all involving intermittent low oxygen therapy. There are also some studies going on in Australia and in Europe. So even though we were the first to start this concept in humans, it's become a very large area of study across many different institutions. So getting involved would mean typing a message to me or one of my colleagues, and we will give you some direction on how to get involved in the research. But again, to put this into a home, given we need to know more about safety and efficacy, we don't want anything to happen to you. So at this point, it's about being safe first, and then how much of an effect can we get that's beneficial. Second. So just contact me.
Dr. Trumbower, we'll do 2 more web-based
Okay.
questions, and then we can wrap it up. One person is asking how this strategy compares or contrasts to training muscles under hypoxic conditions, or even training muscles at altitude. And another person is asking, were there improvements in spirometry measures after the therapy and after the training?
Lots of good questions. So the first question was about ischemic, I believe it was hypoxia of the muscle. So in that case, you're isolating to a single muscle and you're doing this peripherally. The mechanisms that we're imposing are centrally driven, and we believe it's going to have a much more pervasive effect. Second question is about spirometry. So we are collecting those data. It's a double-blinded study. We do not have spirometry data analyzed in our trials right now, but we are collecting those data. And I'm working with Andy Taylor, who's going to be a key scientist in helping us better appreciate some of the respiratory physiology and exercise physiology associated with ILOT. So yes, we are looking at that, but I do not have any results on my end. There is a study showing changes in breathing capacity in humans, and that was published down from the group in the University of Florida a few years back. So there is some beneficial effect that's been shown, but it was a small sample size for sure. So I just want to, I'd love to just say thanks. Thank you for coming out. I really appreciate you coming out and listening to me babble for a few minutes. This is my love. This is what I spent most of my career studying. One of the things that's been the biggest challenge for research in spinal cord injury is involvement. And it can be in any different form. It could be the form of just disseminating and sharing information about what you've learned, questions that you have, whether you found this to be informative or not, doesn't matter. Share. Share the information with your families and with others that have had injuries. Be proactive. I like to think of us as somewhat like activists for spinal cord injury. We're here as a family to eventually uncover a cure, but we don't have that. And so we're making incremental steps towards at least improving the lives of those with injuries, and also caregivers that are having to work with those that have had injuries. And so if there's any way for you to get involved, I can't encourage you enough. I mean, it is extremely difficult to run these trials and to do this research with small sample sizes. The issue really comes down to, do we have enough power to make a change in how we practice rehabilitation? And I would argue that it's not just in spinal cord injury, it's across the board. Rehabilitation research is exhausting. It's time consuming, it's intense, and they're not immediate effects. It's not just, oh, we just pop a pill and we get something, we're done. No, it's grueling. I mean, it is a really hard process, and the research is very much involved and requires a lot of help. So if you have any capacity to assist the research team here at Spaulding, we can't tell you how important that would be to us. In some capacity, it doesn't matter what. If you don't know and you just would like to learn how to get involved, be a part, come to the lab, look at the lab, learn about the lab, be a consumer of the literature, understand my lab is an open door, Andy Taylor's lab is an open door. Our labs here at Spaulding are wide open for you to learn as much as you can and to share the information. We're extremely transparent with our research, and we hope that you guys will stay involved. Thank you.
And I'd like to just take 2 minutes to thank you, Randy, for your efforts in joining us this evening for Knowledge in Motion. Many, many thanks to everyone for attending this evening in person and on the web. and for making your journey out on a Thursday night. Our next lecture will be in January, so look for announcements coming about that regarding both date, time, as well as topic. And again, thank you, Dr. Trumbower. Really interesting stuff, and rehab research is grueling and a testament to all the work you've been able to do over so many years for your passion and dedication and personal advocacy. So thank you very much. Thanks, everybody. Have a great evening.